Hi, welcome to our panel discussion on COVID's aftermath, treating the undiagnosed. So we're going to be discussing the impact that the pandemic has had on both diagnosing and treating illness from both a practitioner and a patient's perspective. We're also likely to touch upon the extent to which the pandemic has exacerbated problems that already existed in healthcare provision in the UK, and in some cases sped up potentially positive trends. With me to discuss these very, very important topics, I have Jameisha Prescod, who's a London-based journalist who runs a platform called You Look OK to Me, which raises awareness and provides support to people living with chronic conditions. Jameisha lives with lupus herself. I also have Shafi Ahmed, a cancer surgeon working at the Royal London Hospital and a member of the NHS Assembly advising the government on the NHS long-term plan. And Clare Turnbull, a professor of translational cancer genetics at the Institute for Cancer Research and an NHS consultant in clinical cancer genetics. She works in cancer early detection and prevention. So if we can start, each of the panelists is going to just talk for a couple of minutes about their subject areas. If we can start with Jameisha, if you can introduce yourself and your work.
Hey everyone, my name is Jameisha. Thanks for that introduction. I run a platform called You Look OK to Me, and I'm also a lupus patient. I got diagnosed in 2014 when I was starting film school. So essentially, I just wanted to create creative content that talked about the chronic illness experience. But in that time, I started realizing as the platform grew and I got to know more people online that have similar experiences to me, that there were many similarities and barriers and so many different social and cultural implications of living with a chronic condition, more than I thought, which has kind of pushed me more into the journalistic side of things, of exploring these stories, but also trying to see what we can do about them and trying to make the sort of patient and medical industry connection and how we can change things for each other. So that's essentially my work. And I also do some of this work for the BBC. So exploring the health and chronic illness implications for BBC Africa, for the continent as well. So that's me.
Great. Shafi, do you want to go next?
And welcome, everybody. Thank you so much for the invitation from CogX for beautiful London. It's so sunny here, so it's great to be here, of course. So I'm Shafi. I'm a surgeon based at the Royal London Hospital. I'm a colorectal cancer surgeon, a laparoscopic keyhole surgeon. And that's been my main interest for the past about 2 decades. And during this next session, we'll be exploring the whole issues around how we recover from this COVID pandemic. And as most hospitals grapple with recovery programs, we'll add some insights into what we need to do to go forward to ensure that we remain healthy and get services back to normal as quickly as possible. From a surgical perspective, I'm talking about surgery, not just in the UK, but globally, also around issues around training. And also how the hospital reconfigured itself from going from more acute to more elective services, how we redistribute the beds better than before with expansion of intensive care, and also how we kind of create more capacity and remodel the effects of hospital. I also share some experiences at the Nightingale Hospital, where I was the clinical surgical lead. We set that whole hospital in a space of about 6 weeks or so. So lots to discuss. I'm really looking forward to discussion. And please do feel free to ask questions. We'll be happy to answer them during the session. So welcome, everyone. Thank you so much for the invitation.
And Clare?
Good morning. Hi, everyone. So my name is Clare Turnbull. I'm a professor at the Institute of Cancer Research in the Division of Genetics and Epidemiology. And normally my main work is around identifying patients who are at high risk of cancer and designing and evaluating means by which we can either prevent or detect their cancers earlier. And apropos of this session, back in March 2020, I redeployed myself back across to my clinical role in the Marsden Hospital, and was there really sort of thinking and working with the team there about which patients we should prioritise for surgery, given the restrictions on access and availability to surgery, and also the concurrent risks for cancer patients around development of COVID-19. And so we were really looking very directly at what was happening in terms of the breakdown of the pathways for patients into their cancer diagnosis, their pathway through diagnosis, and their trajectory through to their different types of treatments, so surgery, chemotherapy, and radiotherapy, and trying to model what would happen to different groups of patients due to the different COVID-related delays. So those are the insights I'll be bringing to this discussion, both what we found from the original modelling, but also how it played out over the following 14 months.
Great, thanks for those introductions. So based on that, I have a question I think that's for both Claire and Shafi. So I think we all know, it's been widely discussed, that a lot of patient care and diagnosis has been delayed. So there's this kind of sense of an impending backlog. I wonder if you can talk a bit about what that looks like on the ground, how you've experienced that, what you've seen. I know some people hate the expression "on the ground," but what you've seen from your patients and from your work. And also, is there any preliminary evidence around the effects that those delays have had on patients' disease progression and also on their clinical outcomes? Or is it kind of just too early at the moment to say? So I don't know if one of you wants to go first there.
I think in terms of the initial situation, I think we all saw cancer services grinding to a halt. That was in part to concern about protection and whether we were going to do more harm than good to our patients by bringing them into or keeping them in hospital. In part, massive staff sickness, in part, staff redeployment, and in part, the pathways becoming unglued. So we saw on the ground things really slowing down and then being very slow, depending on the different settings, to get started again, and various challenges in starting again. In terms of the delays and what we can see now in the data, there's a big gap in patients. There are 40,000 patients who typically would have been diagnosed with cancer in the last 14 months. They are not yet in the system. So there's a big bulge that is still waiting to come through. That's one issue. There's data now clearly that patients are being diagnosed at a more advanced stage of cancer. That's very clear. And we also know that while the NHS is really doing incredibly well at trying to squeeze every last drop of energy, doing surgical lists on a Saturday and so forth, trying to really do everything they can to catch up, there's still substantial delays, particularly in patients coming through the screening system. So bowel and breast screening who have been picked up, who then need the next step of their investigation. In services for sort of non-urgent investigations, so people who are maybe having regular colonoscopies because of a family history, and so forth. So I think those elements of the pathway are really still struggling to catch up as well. So I think that the data on the ground are, the NHS has really bust a gut to deal with the situation, but there are substantial delays still. And also there are patients who are out there. There is still a bulge to come through the system, and that presumably we think is patients who still haven't presented with their symptoms, that they're just waiting longer to come forward, which again would speak to those later diagnoses.
And do you think part of that is fear of even presenting at the hospital, and that's fear of catching COVID? Is there an element of that still?
I think in part, definitely in the acute phase, there were two messages. One, protect the NHS, so people dutifully sort of stayed at home with their non-emergency symptoms, and then of course the other one of a reasonable fear of going into hospitals, and a sense of wanting to delay that. I don't know, Shafi, does that speak to your experience on the ground?
Yeah, I think you're absolutely right, Claire. Back in the early stages of the pandemic, there's certainly a fear factor. There was hardly any social admissions on the ward, for example. People were at home with appendicitis, with chronic, with acute abdominal disease, for example, not coming in. We saw the same thing with heart disease. People weren't coming in with the same problem. So there's a fear factor. there was people were uncomfortable coming in when there was COVID on the wards. That's changed. Now the vaccine's introduced and people are much more confident, both on the clinical side and the patient side, we're seeing more patient engagement. So, for example, I'm now re-established face-to-face clinical appointments for surgical patients over the last month or two. And now we're seeing patients coming in regularly. What we're seeing, where patients were delayed for treatment, they decided that they put it on hold, or the hospital had no capacity to see them, they could see them virtually on a telemedicine consult or telephone consult. Now they came back demanding to be seen earlier because they've had problems for quite some time, they're suffering, now they want surgical operations. And that's the change that's happened over the last few months, I'd say. And I'd say the vaccine would help that. Also, as hospitals opened up now with more capacity, opening up clinic space, opening hospital beds, for example, going from more red to amber to green areas, which is like the clean zone, we're now seeing that manifest itself with patients coming to see us. We still get the other problem, of course, is that we have a huge backlog of patients for clinics. So I'm still seeing patients now who were referred over a year ago or made back in 2019, if you can imagine that. And some have forgotten about why they want to come and see us. Some are frustrated. And so now we're trying to understand who needs to be seen and managed. And that whole piece of work is part of the recovery program to ensure the right people get the right treatment as soon as possible. And if you look at in terms of the impact that's had, say, for example, say in mobility orthopedics, there's been some papers written, I guess, recently on what the impact that might be. Claire's mentioned cancer. Obviously, delays are not good. You go from stage 1 to stage 2, 3, and 4, and delayed presentations, big operations, more complicated operations, and more worse outcomes. Even elective situations like joint replacements, hips and knees and things, which have a huge burden of problem in the public. We're seeing people with more pain, taking more open analgesia, more prescriptions, for example, in that time space, poor quality of life. We've seen kind of them coming to having more appointments on a kind of virtual basis. And of course, if you do operate on patients after 6 months of waiting, there's a 50% chance of worse outcome just on elective surgery and not even cancer. So we are seeing impact. Of course, who knows about the impact of mental health on patients who've been waiting for ages on this. So lots to discuss as we go forward and how we recover, of course.
And speaking of that, Jameisha, I wonder whether you could come in and maybe talk a bit about the psychological impacts that these delays are having on patients or might be having on patients from discussions that you've heard and that you're involved with in your group.
So when it comes to psychological impacts, it's really, I mean, it's easy to say that now is a very difficult time. And I think when it comes to patients that present with chronic illnesses like myself, where they're long-term or they're undiagnosed, they know they have something that is consistently bothering them pain-wise, fatigue-wise, but they're not quite sure what it is. It's very challenging because there's already sort of a little bit of a distrust in the chronic illness community when it comes to the medical side of things, because there was already like an extended period when it comes to diagnosis for a lot of chronic conditions. So I myself, for example, waited 7 years from when I was first presenting with my symptoms to figure out that I had lupus. If you're already somebody that had to wait 7 years or are still waiting, then seeing that there is a pandemic that's going to cause further delays, it can be demoralizing. It could be that you actually just give up. There's a lot of fear and a lot of like complexity in that. And I mean, I am currently also in a state where, while I have been diagnosed with lupus, I'm in the process of trying to diagnose another condition that's really painful, which, just like Shafi mentioned, I have to take opioids for because the pain is that severe, but I actually still don't know what it is. And the extended times of waiting is the fear of how long should I take these things? What's going to happen to me? What happens if I go there and it's actually become a lot more serious than I thought it was in the first place? It's just a lot of fear and anxiety and a fear of the unknown. And we're already kind of trying to bridge that gap with your medical professionals to have that trust there. And it's harder to have that when you can't see them as often and it takes a longer time to be seen.
And yeah, you mentioned it took 7 years to get the full diagnosis. And I think people were talking a lot about backlog of undiagnosed care and attaching it to the pandemic. And Claire, I think this is probably a question for you. I wonder how much of these problems of undiagnosed care precede the pandemic and might be kind of more structural in nature, and how much of it is caused by it.
I think you're completely right there, and Jameisha's experience is not atypical at all. I work in my clinical work is in cancer genetics, so patients and families in whom there's a high risk of cancer due to a genetic basis. But my colleagues work in diagnosing other genetic conditions, and often the so-called diagnostic odyssey. If you have a complex multi-system disorder such as lupus, or often typically we see sort of children with developmental disorders, it can take years and years of bouncing between different specialties, having different investigations and letters back and forth and so forth, which has numerous implications for the patient, and also couples often don't go on to have another child because they're not sure about the diagnosis in their first child in the context of children with developmental delay and so forth. So this is in a number of realms. There are pathways can be slow. And then you add the global pandemic on top, all of the concern about infection, all of those pathways grinding to a halt, the glue falling out of the system, blocked access to primary care, and it just widens those cracks in the system. But those cracks in the system were pretty substantial ahead of COVID-19. I think I would cite two very substantial issues there. One is workforce planning, that we keep talking about expanding the number of doctors and nurses that we need. We keep talking about it. It takes at least 10 years to train a consultant, more typically 15, 5 to 7 years to train a nurse. We need to act on this, that many consultant specialties are 30% down. We need to get those people coming in the front end. We need more nurses. For decades, we've stolen nurses from other countries. So they've paid to train them and generate the numbers, and then we pull them into our country. But A, that's unfair, and B, actually with increased complexity around visas, immigration, and particularly Brexit, that's becoming actually less of a successful strategy. So we've got a real issue with workforce, which we've known about, and has just been brought to the fore even further. And then the other one, I think, is around technology, that informatics and technology is the lifeblood of any system, but actually our ways of capturing information, our ways of communicating between different elements within the healthcare system, our ways of using intelligence. So we're taught at medical school how to think about diagnoses and how to arrange our ideas of sort of probability and evidence and actions, but we don't actually have the matching systems, the information systems, which harness that. So I think there's a lot is lost, and a diagnosis of lupus would be a sort of an archetypal example of how actually something which linked thinking together better and information flowed better, that 7 years to diagnose lupus, that's just not good enough. We should be able to do much better than that. But I think the staffing and the technology are two such fundamental issues, both of which were exacerbated and laid bare during the pandemic.
Since we're talking about some of the solutions or pathways to improve the situation, I wonder if I can turn to Shafi and just ask, what are some of the ways that have been posited to address the huge backlog we're seeing, and what do you think will be needed in terms of investment, resources, and new technologies? Claire's already talked about a few. Do you agree with them? Do you think, is there anything you'd kind of add to that?
So so let me think about some numbers that we have at the moment from a surgical perspective, and we'll elaborate further with the technology side. If you look at the current situation in the NHS, just in England alone, there's about 5 million people who are waiting for a surgical intervention, and 436,000 have been waiting more than 1 year. Pre-pandemic, it was less than 1,500. So you can see the dramatic rise in patients waiting for surgical intervention. So that's kind of the context on a NHS England or national level. Globally, look at the first 3 months of the pandemic back in last kind of April, May, June. And within 3 months, the global aspect was that 28.4 million operations were cancelled in the first 12 weeks, of which 2.3 million were cancer surgeries. So 72% of all operations were cancelled or delayed in that first context. So that's a huge backlog. The problem, of course, is there's no point going on about that. We know the numbers. How do we overcome it? Absolutely. So Claire's right. Data is important. Do we need to see everybody again? Who's on the waiting list? What's the problems? How do we maximize the opportunity for them, stratify them properly, and then perhaps triage them appropriately? That's the first thing. Big data piece is done. around how much capacity we have and remodel that kind of work. So if you look at the RCS, the Royal College of England, who looked at the kind of ways and provided some, I guess, recommendations, it goes back to creating a workforce that's relevant and big enough and large enough. That's going to take years to get back. How do we repurpose what we have already? So hubs, surgical hubs are one issue. So people saying we need 40 more surgical hubs across the UK. And St George's actually have actually in 3 months created a surgical hub at Queen Mary in Sidcup with 4 brand new operating theatres all working to capacity. So we can do it very fast as the Excel Centre where I worked being in the pandemic. So it's that fast attraction of a capacity and remodelling it. Workforce is a problem. You know, we had just enough staff to maintain healthcare service, and 10% were ill during the pandemic, and we struggled to fill those places. I was doing an intensive care shift, for example. We just helped support nurses on the ward, for example, intensive care back in January, and we were under a lot of pressure. So that's part of it. Next, about how do you support staff as they recover and had a whole year of anguish, mental anguish, and really hard work and overburdened by the workload. Technology is a key factor. I'm a kind of technologist, I'm a futurist, that's what I'm known for. Technology has played its part. We're now looking at telemedicine, we're using that more, and I think the utilization of telemedicine was up by 8,000% in the first few weeks of the pandemic. We're doing telephone consults, looking at data, remote monitoring, we're seeing patients remotely, etc. So people with chronic diseases like diabetes or COPD are managed a different way. And HSX is doing different plans around managing maybe hypertension or other diseases in the community. So maintain this kind of way of managing the acute sector for what it's worth and pushing everyone back into the community to ensure that the money and resources are used much more effectively. And the ICS can be part of that conversation as we go forward. So solutions are repurposing, remodeling. Actually, maybe this is an opportunity for us to sit back and say, how can we do better? It hasn't worked for years. Winter planning has never worked for years. How do we now remodel our workforce accordingly and what we need to do with the hospitals? And so I think that takes major discussions around repurposing healthcare for the future. That's great, thank you.
I want to shift gears very slightly here and ask Jameisha. Those are kind of the I think Clare and Shafi have outlined some of the broad brush innovations and structural changes that could be taken, but I'm wondering which groups in society do you believe are kind of most likely to be left behind when it comes to diagnosing diseases at the moment, and how might they be accessed better? So kind of, you know, outreach. And then I wonder whether this past 15 months has changed some of those slightly more marginalized groups' access to healthcare at all.
Well, I think we've been seeing more of these conversations come up lately when it comes to certain types of groups with more barriers than others to healthcare. Within the last year, we're having conversations about the Black Lives Matter movement, and therefore health about Black, Asian, minority ethnic people started coming up more in terms of the worst health outcomes. So if you're asking for a certain group, it's, you know, people of color tend to face worse health outcomes than other groups. Also, when it comes to people of lower socioeconomic class, and also about gender as well. So if we look into like gynecological health, trans people and non-binary people oftentimes have barriers to entry. So a lot of the time, marginalized groups prior to the pandemic were experiencing these things. I'm not sure if that has been made better in the pandemic, probably not, but the conversations are happening, not necessarily due to the pandemic, but some of the other things that have been happening over the last year, which I'm glad. I'm just hoping, to be honest with you, the way to move forward is to have more conversations about it. One of the perfect ones I saw lately was the skin conversation, right? So people started realizing that darker skin, like mine, oftentimes skin conditions will present differently. I have lupus, and when I had my lupus rash that came across my face, it wasn't bright pink like every single place was explaining it to be. Because I have dark skin, it was brown and purple. But if you type in lupus rash into Google, you will see mainly white people, light skin. So the fact that these conversations are happening, the fact that more people are like, oh wow, there's actually structural problems here that, first of all, the pandemic didn't cause, but it's probably going to make worse. How do we build as we wind down the pandemic, hopefully, eventually? How do we build from there? So I'm not sure if it's kind of gotten better at this current stage, but I'm hoping that the more conversations we've had about people having these barriers can hopefully build a better health system for all of us later on, and help the fact that, like, you know, during those sort of the training stages for medical students, that's being implemented early as possible. Because I myself, as someone with a chronic condition, have heard things that simply were not true from people, partly due to my ethnicity. And it can sometimes make you disenfranchised with the system and not want to go, like not want to turn up to the doctor because you think you're just going to be dismissed anyway. So I'm just hoping that with the awareness and the conversations we're having, that when we start to change the way things are going, after we come out of this pandemic, that those are included too. Also, that access remains after the pandemic sort of winds down. So telemedicine and things like that, a lot of people now have much more access to healthcare based on their disability. So people are scared, for example, that will go away after lockdown ends and the pandemic ends. And we're hoping that stays in place too. So yeah, it's just it's a lot of groups affected in that way, and I think we have an opportunity to change that.
Yeah, I was kind of wondering whether some of the medical interventions we've seen in the pandemic, which have been kind of quite groundbreaking, people testing themselves at home, people being contacted by the government regularly about their health, whether that has actually brought the health system into people's homes in a way that especially kind of more marginalized groups, in a way that we haven't seen before, and whether that could be harnessed going forward.
I think this pandemic has made a lot of people realize that you can get ill at any time. And, you know, I don't think a lot of people were thinking about that before. A lot of us with chronic conditions, yeah, doctors, sure, but not the majority of other people. And then to see there are people who were walking around completely fine, were infected with COVID and now have long COVID. They now have a chronic illness. I think it's making people realize, wow, this, you know, like being healthy is not always going to be a consistent thing, and that actually things can change very, very quickly. So I do think that has had an impact on the general kind of viewpoint and conversations that we're having surrounding healthcare in general.
I want to return to something that Claire, you mentioned before in terms of prioritization of care. And I'm wondering whether you think that the pandemic has kind of accelerated a hierarchization of disease. So what factors are at play that mean that some diseases are prioritized over others? And if that's happening even more than it was before, what kind of effects is that likely to have, both in terms of care, but also in terms of the patient experience?
I mean, I think definitely it's brought a lot of, the pandemic's brought a lot of those debates to the fore, not least the issue of shutting down some elements of the healthcare service effectively in order to prioritise treatment of COVID-19. That in itself was a sort of generated controversy and arguments about prioritization, resource allocation. I mean, certainly within the cancer world, we have patients who, if you can get them managed and operated on quickly enough, you are doing with that with the aim of curing them. So if a 50-year-old man comes in with symptoms, is diagnosed with bladder cancer, you operate quickly enough, you increase the likelihood that he has been cured, i.e. he will live to a normal life expectancy of 80 or whatever. So there's a lot of value, and particularly during the pandemic, a lot of priority was placed on prioritizing patients who have potentially curative disease. In cancer, you also have patients who are known to have non-curable disease, but they may be able to have life-extending surgery, chemotherapy, radiotherapy, or whatever. And for them, the difference between 8 months and 3 months is very substantial as well. So those are two very different scenarios, and how you prioritize those two different groups of patients is very challenging. Looking beyond cancer, you then have the situations that we've already discussed, and Shafi mentioned in regard of orthopedics, a 75-year-old who is now chair-bound because of her crippling arthritis pain. So her arthritis isn't progressive; it's not going to kill her. But at 75, she only has a certain number of good years left, and she's sitting there losing them because because she's waiting for a relatively simple surgery. So weighing up between, yes, progressive diseases like cancer and non-progressive diseases. And then always, and cancer again is an example of this, do you prioritize the young over the older? So do you prioritize the 40-year-old who has a potential life expectancy of over 40 years over the 60-year-old, over the 70-year-old, on the basis of their potential life expectancy? And I think these are all challenges which there is an undercurrent of in terms of prioritization and health spend, and they were really brought to the fore during the pandemic because quite acute choices and prioritizations had to be made.
Before I ask Shafi if he has anything to add, we've got about 5 minutes left. So if anyone has any questions they'd like to ask our panel of experts, please send them in now. Shafi, do you have anything to add there about when it comes to making decisions about which patients should receive surgery or receive care, and how those decisions are made, and whether you've talked about maybe some tech innovations? I wonder if that's a way of maybe trying to sort through that hierarchy.
Yeah, I think that sadly the last year we've had to make some tough choices. Patients with cancer, patients with other diseases, and not just surgery, of course, it's every discipline in the hospital. What I'm really encouraged by, let's be positive towards the end of this conversation, but now we're at the other end, almost seeing the kind of the light at the end of the tunnel. We're seeing now patients coming to us with different problems who haven't been seen before. We're now putting on lists for them for the operations, so the expectations is much better. Still, there's some delays, there's no question. But now patients are much more optimistic about getting treatment at the right time. So, for example, I'm doing 2 lists or 3 lists in the next few weeks, extra lists to accommodate patients with hernias, who've been there for 18 months with their hernias, with discomfort and pain. Now they've got opportunity to have the operations in a clean zone without COVID and being risk-free. So I think we're moving ahead. I think the expansion is the key for us all. How do we expand the services? How do we have enough diagnostic tests? How do we have enough personnel to manage that increasing workload, which will come? I think that's the planning that's needed to happen. And that's going to be done by data alone. So I think with the ability of the ICS, with the data now being available to NHS, it's now planning that next year, 18 months for the recovery program, which I think we should be excited about. So look, we are finally giving patients treatment they deserve.
Great. Yeah, exactly. That's exactly what I was thinking about in terms of harnessing data that's available to try to improve pathways. I think it's something that's been talked about, and I think there is some controversy around that, and I wonder whether there's any that you'd be able to elaborate on that at all, maybe Clare or Shafi, what it is that's behind the controversy around using that data and how you think it could and should be used.
I guess there is only one opt-out, and there are all manner of potential uses of health data. So as a researcher, health data is really, really useful because it lets us see, which types of symptoms best predict a cancer diagnosis so that we can prioritize patients better. It lets us see how patients are moving through the system so we can design systems better. But the data usage opt-in, opt-out is for all manner of healthcare and health services research and commercial research as well. So I think there is a level of concern and anxiety out there in the public around sharing of data with commercial entities and what that might mean. But for the former use cases, I think those involved in health services and health-related research are very concerned about the likelihood of people opting out of use of their data.
It's quite simple. And the last thing I would say, just that it's about honesty, transparency, engagement with the patient and the public. That's the key to understand how data will affect our lives. We haven't done that well enough. We've always been scared of approaching this conversation. patients are far more receptive to new ideas than we'd ever imagined, and the pandemic has shown that beautifully.
But I think, I mean, as Shafi said, we need to know where the patients are in the system, and that's a bit better. And there's Health Data Research UK, large investments, large funding, but it's still at best we get a few weeks lag, and we can glue together different data sets and get a little bit of an overview. I mean, if Amazon know where every parcel they're delivering is at any moment in time, and what's in that parcel and who it's going to and when they ordered it, if you're explaining it to an alien, it's a little bit disappointing that we can't have that level of visibility of where our patients are in the system. So we are getting better, but it is still a real challenge in seeing which patients are where and for what reasons within the pathways. And it seems, as Shafi said, we're only going to be able to improve the systems as much as the data enables us to do that.
Well, I am going to have to wrap up because we've just hit time. It's 12:40 here, 11:40 where you are. Thank you so much. It's been an absolute pleasure, and I think we could carry on talking for hours, but we'll have to continue the conversation in the public and offline. Thank you so much, everyone.
Thank you.
Thank you.